So this is a picture taken in much happier times of Vicky Marlowe and myself at the American Academy of Orthopedic Surgeons meeting in San Francisco. And Vicky was the best informed layperson I knew about hip resurfacing and other hip devices. She was a patient advocate, and she took her role extremely seriously and worked very, very hard informing herself and informing hundreds of patients about their options for treating their arthritic hip. She was one of life's real enthusiasts for the operation of hip resurfacing, and of course she had 2 hip resurfacings herself. It was a real shock when all of us learned recently that she had died from a bizarre illness, and we are all terribly sad about that, and the patient community is all the worse off. So I've decided to do this talk as a tribute to Vicky. Metal-on-metal joints are not new. We have a 50-year history of using metal-on-metal joints, thanks to McKee and Scales and Peter Ring and some others. We have had the opportunity of using all of these inventors' joints at the Royal Orthopaedic Hospital in Birmingham, and I've had the privilege of following up patients who have had these implants. We've got some very long-term follow-up. The patient in the center is on our website, and she's 42 years follow-up now from her Stanmore metal-on-metal hip. When I started to think about the options for hip resurfacing in the late 1980s, it was clear to me that with the technology available at that time, that metal-on-metal offered a chance of working, because hitherto no material had worked for hip resurfacing. The wear of these devices was extremely low. This is one Ring device that I removed 23 and a bit years after Peter Ring put the joint in himself. 10 microns of wear on the head and 8 microns on the cup. Exceptionally low wear in a high clearance joint. So after 2 years of working on this, this was my first design of metal-metal resurfacing when I started that series in February 1991. It was not entirely successful. We had, for various reasons, no porous coating on the cup or the head, no hydroxyapatite coating, and no cement. These were pure press fits. However, we have followed up quite a number of patients now for 20-year review with well-functioning implants. I then carried out a small series of hydroxyapatite coating on the cup and the head, and the cups were excellent and still remain excellent, but the femoral components were not ideal, and in this tiny series, 2 of the femoral components loosened. I then tried cementing both the cup and the femoral component, and the femoral component was perfect with 0 failures, but the cup was terrible. Cemented metal cups had micro motion at the implant cement interface, generation of cement debris which caused osteolysis, and a very high failure rate. So from that little pilot study, it was clear to me that uncemented hydroxyapatite coated cups worked and cemented femoral components worked. So in March 1994, we started the hybrid series. This is a patient from Birmingham who I know well, and there's his 2-year and his 15-year follow-up x-ray. He is extremely active and a very keen golfer. I have since resurfaced his other hip and carried out a knee replacement on him. The series of patients with that device put in during 1994 and 1995 were, it turned out, the first successful hip resurfacing implant. And 107 of these hips had a 96% implant survival at 10 years. I then started to develop some confidence in the method and increased my numbers. And unfortunately, as the company who manufactured these devices had to increase the numbers, they found that they were getting too high a scrap rate for microporosity in the metal, and they decided to double heat treat with hot isostatic pressing and solution heat treatment the components. And I was unaware of this at the time, but it turns out that that double heat treatment led to a deterioration in the outcome, and that series, unfortunately, with double heat treatment has an 86% implant survival at 10 years, and unfortunately those implants continue to deteriorate and fail. The double heat treatment partially dissolves or wholly dissolves in some cases the carbides, which are the hard ceramic-like wear resistors in the material, and leads to increased wear. There's a patient at 10 years who hasn't failed, but you can see osteolysis in the acetabulum and in the femoral neck. This is a patient at 4.5 years, and I've since revised this patient's hip, and you can see again osteolysis in the femoral neck and in the acetabulum. When I discovered that the company had been double heat treating the implant during 1996, I asked them to stop. They did not wish to do that, and so Corin and I shook hands and went our separate ways. Ronan Tracy and myself set up Middle Medical Technologies, and with the help of a lot of other people, in particular Tim Band, who at the time was with Centaur Precision, and Mike Chuk, we developed the Birmingham hip resurfacing. So I'm going to show you now my Birmingham hip resurfacing series, which was started in July 1997. I'm going to show you the outcome of my first 1,000 Birmingham hip resurfacing patients, done between July 1997 and August 2000 in 886 patients. My team have worked very, very hard to follow every single patient in that series, and we have a no loss to follow-up. Here are the primary diagnoses. The commonest diagnosis, of course, is osteoarthritis, but there's a difference between the men and the women, which I shall show you. In women, there's a much lower percentage of osteoarthritis patients. In dysplasia, women have a much higher incidence of dysplasia. Here's the age distribution, with the commonest group of patients between the age of 50 and 60. They're now 13 to almost 16 years down the line, so they're that much older. And in this series, there was a 2-to-1 men to women ratio. We've done Oswestry hip scores, Harris hip scores, Oxford hip scores, and UCLA activity scale scores on all of these patients, and they look good. I'll just hone in on the UCLA score, and this is at the latest follow-up. The mean is 7.8, which means that even though these patients are now getting elderly, there's still a high activity level, with the commonest group, UCLA grade 8, regularly participates in active events such as golfing and bowling. When we follow the hip scores with the passage of time, those are Oswestry hip scores, and they tend to remain stable over time, so there's not a deterioration with the passage of time. When we look at patient satisfaction score, if we just cast your eye on the first 402 BHRs done, then at 10 years they had a 100% either extremely satisfied or satisfied. When we look at the first 1,000 patients out of 12 to 15 years, they had a 99.7% extremely satisfied or satisfied. So those patients report very good outcomes from their implant. Running through some of the other findings on X-ray, when we look for evidence of loosening and migration, on the acetabular side, 95+% of patients have no radiolucency, and there were no cup radiological failures. On the femoral side, again, 96% no radiolucencies, but here there was one radiological failure, a patient with collapsed femoral head and implant migration, but because the patient had no pain and was functioning well, has not been revised. When we look at Bruker classification of heterotopic ossification, most of the patients, of course, have no ossification. 7% of grade 1, 3.2% grade 2, and 1.6% grade 3. So not a lot of heterotopic ossification in this group of patients. When we look at inclination angles, the mean is 42 and a bit, and of course that is entirely satisfactory, but I am less than happy with 3 patients at the top, you can see there, with inclination angles over 55 degrees. This matters because, particularly with smaller implants, if you have high inclination angles, then you can get severe edge wear. These 3 patients didn't happen to get edge wear, but that was lucky. In my defense, these were my first BHR patients, and so we were not as focused on getting absolutely spot-on inclination angles at that stage, but we soon became very focused on inclination angle. The most difficult aspect of this group of patients is in relation to anteversion. And this is a group of 351 patients who had successful BHRs and had Mars CT scans 10 plus years after operation. And if you look at the men and women, men have a femoral neck anteversion from -7 to +40, but women have a femoral neck anteversion from -33 to +49. It is very, very difficult with this range of femoral neck anteversion to get a cup positioned to give a combined anteversion of 45 degrees. But seemingly I have managed reasonably well because all of these were successful BHRs. When we look at those Mars CTs, there's a splattering of other pathology on the opposite hip. Most of them had resurfacings on the other hip, but some total hips, BMHRs, normal hips, and 81 arthritic hips. Here's a selection of some Mars CT scans. This patient on the right side has a standard metal on polyethylene total hip replacement, and on the left side, a BHR. As you can see, arrowed are small fluid collections at the front of both hips. No different on the metal polyethylene to the metal on metal BHR sides. Here's a patient with an arthritic right hip and a left BHR, and both have medial fluid collections. Here's a patient with a right BHR and a left arthritic hip, and on the right there's a small anterior fluid collection, and on the left with the arthritic hip there's a large psoas effusion. We've classified all these as pseudotumors and fitted them into the classification of Matthews, and we have a small percentage of fluid collections in this group of patients. We have no solid pseudotumors. Interestingly, we have apparently less fluid collections in the resurfacing patients compared to those with an arthritic hip. So here we've got blood cobalt measurements in a group of the first 1,000 patients with unilateral BHRs in them, but no other metallic implant. And you can see that 3 of the patients have cobalt levels that are above 7. Now you will recall that I pointed out to you that I had inserted 3 of the patient's implants with inclination angles above 55 degrees, but rather annoyingly they don't match. So the 3 patients with high inclination angles do not in fact have high blood cobalt. The 3 patients with higher blood cobalts are all absolutely clinically fine. The question is, how do we interpret this sort of information? And quite interesting evidence was given by a toxicology expert at the first ASR trial in California. Cobalt, of course, is an essential element. You have to have it in your diet, otherwise you die. And we know that in Australia, there's one area with cobalt deficiency, and the sheep die unless they are given cobalt supplements. Now, cobalt supplements are not unique to sheep. They are in a number of health food supplements that you can buy over the table without prescription. The evidence given in that ASR trial was that if you give a group of healthy volunteers cobalt supplements, then it's interesting how high their blood cobalt levels go. For men, they recorded levels as high as 40 micrograms per liter, and for women they recorded levels up to double that. So high cobalt levels in the blood certainly seem to be possible just by taking across-the-counter health food supplements. I'm now going on to discuss revisions in this first 1000 BHR group, and there have been 38 revisions. Here are all the causes of revision together with the time and the time to failure and whether they're men or women. Now, the commonest cause of failure is femoral head collapse. There were 13 of those. And the big culprit in causation of femoral head collapse is a pre-existing diagnosis of avascular necrosis or pre-existing femoral head cyst formation. The next common problem was adverse reaction to metal debris, and there were 7 of these, and these patients were revised on average at 10.6 years from operation. All of them were women. Most of them had hip dysplasia, and implant retrieval in the main showed edge wear of the cup. Now, these in fact were easy revisions. They all had 1-stage revision, and they have all been successful. There were also 7 deep infections proven with microbiology and histology. These patients were revised at an average of 5.1 years from operation, 6 women and 1 man, and these patients had 2-stage revisions. So I've had much more trouble with a deep infection than I have had with adverse reaction to metal debris, and both had a 0.7% incidence. There's the survival graph for those first 1,000 patients. 95.8% implant survival at 15 years in men and women. When you break it down into men and women, then men do significantly better than women. When you break it down into gender and age, then it's quite interesting. The best results are in men who had their operation age 60 and above, closely followed by men under the age of 60, closely followed by women over the age of 60, and the worst results were in women under the age of 60. So you can see that women over the age of 60 have a 96% 15-year implant survival, and women under the age of 60 have a 91% 15-year implant survival. The next important piece of information is to break down by diagnosis, and you can see that dysplasia and avascular necrosis have worse outcomes than all other diagnoses put together. Here we've got the table broken down into men under and over 60 and women under and over 60. And you can see that women under the age of 60 have only 56% osteoarthritis, whereas women over the age of 60 have 89% osteoarthritis. When we look at avascular necrosis of the femoral head in women under and over 60, 6% in the women under 60, none in the women above 60. When we look at dysplasia in women under and over 60, 24% in women under the age of 60 and only 7% in women over the age of 60. So these young women, by having a disproportionately higher percentage of avascular necrosis and dysplasia compared to women over 60, have a worse outcome from their hip resurfacing. When we break down the outcomes in women by head size, there is no obvious relationship. Again, in men, there is no obvious relationship between head size and failure. I am, of course, aware that there are some National Register results, both in UK and in Australia, which show that the smaller the head, the greater the failure rate. But as you can see, my series does not show that. And the point is that head size alone is not a cause of failure in metal-on-metal hips. I have a series of 28mm head Metasol patients who are all above 13 years now, and they have a 0 failure rate. So small heads alone are not enough to cause failure. However, when the head size is small, then by cup malposition, in small sizes you get onto edge loading and edge wear quicker. So you have to be all the more accurate in your implantation with small sizes. And I think I'm reasonably good on component orientation, and that's why my series, unlike a number of other series, show no relationship between head size and failure. So there's again the survival graph of my first 1,000 Birmingham hip resurfacings. And the green one is a very interesting graph. So that data was collected by the Oswestry Outcome Centre, and this is a group of 3,762 Birmingham hip resurfacings carried out by 141 surgeons in 44 countries. These surgeons were all taught how to do the procedure by us, and you can see that they've got a very creditable 95% implant survival at 10 years. So this procedure can be taught and can be done by many other surgeons. The orange is the Australian National Register results, and they have a 93.7% implant survival at 10 years. Again showing that this procedure can be taught and can be done by other interested surgeons. This is the first patient to have a Birmingham hip resurfacing on July the 30th, 1997, and this is him when we did his 15-year follow-up review. There's his pre-op x-ray, 1 year, 5 year, 10 year, and 15-year x-rays. He is both clinically and radiographically perfect. So why do I continue to carry out hip resurfacing? The first reason is that hip resurfacing has better function compared to total hip replacement, and I will show you the evidence on this in a minute. The second is BHR in young people has a lower revision rate compared to total hip replacement, and again I'll show you the evidence on this. And the third reason I continue to do hip resurfacing is that the BHR in men has a lower death rate compared to total hip replacement. So the best evidence to show that hip resurfacing has better function compared to a total hip replacement is from Professor Justin Cobb in London, and he has looked at patients and controls on a treadmill. And what happens here is that the patient warms up and starts walking faster and faster, and the goal is to get to their maximum pace, which is then measured. So he recruited 22 total hip arthroplasties and 22 hip resurfacing arthroplasties, all based on good hip scores. And he recruited an equivalent number of healthy controls. Here are the results. The controls and the hip resurfacings had a significantly higher walking speed than the total hip arthroplasty patients. They were 9% slower than normal and hip resurfacing arthroplasty. You will recall at the first of his Olympics, Usain Bolt in the 100 meters was 3% faster than all the others. That's what 9% looks like. Two further function studies from the same research lab show that the stride length is significantly shorter with total hip arthroplasty as opposed to resurfacing, and the load acceptance through the leg is greater with hip resurfacing than with total hip replacement. So there is independent, objective evidence that hip resurfacing gives better function than total hip replacement. BHR in young people has a lower revision rate than total hip replacement. I have carried out hip resurfacing on a number of different pathologies, and all of these patients and many more like them are in my series. Avascular necrosis, multiple cysts in the femoral head, dysplasia with various degrees of difficulty, dysplasia with previous surgery. These diagnoses all carry a higher failure rate, and I rather wish that they weren't in my series, but these and many other like them are in my series and cannot be removed. When I look at my total series with a minimum 2-year follow-up, 3,205 patients out to 15 years, 96.4% implant survival at 15 years. All ages, all diagnoses. You can see that that is better than the NICE guidelines, which is 1% failure rate per year. When you look at the survivorship of failures, there are a number of different resurfacing arthroplasty devices, all from the Australian National Register. Here is data from the Swedish Register, 3 different series of total hip replacements, not much difference, and those patients were carried out up until the end of 1998. My series of resurfacing started in the middle of 1997, so there is a 1.5-year overlap in series. So the worst results in the total hip are a 67% failure rate at 16 years. My young patient osteoarthritis results show a 98% implant survival at 15 years. So hip resurfacing compared to conventional total hip replacement certainly appears to be an advantage. Now, it will be noted that in this time period, the type of hip replacement carried out was generally using conventional polyethylene. It is thought that the 16-year results of cross-linked polyethylene will be significantly better than this series, but we're comparing during a similar time period conventional total hip replacement with an unchanged Birmingham hip resurfacing starting in mid-1997. Women with conventional total hip replacement have not very good results, as you can see. Women, of course, young women with the Birmingham hip resurfacing, as I've already shown you, are a group with a high failure rate, and the BHR group represent that, but nonetheless, they are significantly better than conventional total hip replacement. The most contentious issue is that BHR in men has a lower death rate compared to total hip replacement. There have been a number of pieces of evidence over the years that have made us suspect that, but it wasn't until a couple of years ago that we were able to get hold of National Joint Registry data to be able to analyze it and see what was going on. In this publication a year ago in the British Medical Journal, there are 2 statisticians from the Biostatistics Department at Birmingham University. There are 2 directors of research, and two surgeons, myself and Ron and Tracy, cheering this group of scientists on to greater and faster things. The first thing in men and women, total hip replacement, if we look at the revision rates, it is absolutely the case that cemented total hip replacement has a lower revision rate at 8 years than uncemented total hip replacement. However, when we look at death, the right opposite is the case, and there is a significantly higher death rate in the cemented total hips compared to uncemented total hip replacements. When we look at men only, the lowest revision rate is with cemented total hip replacement, followed by Birmingham hip resurfacing, followed by uncemented total hip replacement. However, when we look at death rate, overwhelmingly the lowest death rate is in the Birmingham hip resurfacing group, followed by uncemented, and significantly followed by cemented total hips, and the cemented total hips have the highest death rate. Now, these were fully adjusted for all the confounding variables that were available to the statisticians. And what this means is that the penalty of performing a cemented total hip arthroplasty in men, as opposed to performing a BHR, is one extra death every 23 procedures over the ensuing 6 years. When you add that up to a national and an international level, that is a lot of unnecessary deaths. Now, there are two surgeons in there who have been the inventors of the Birmingham hip resurfacing, so you've got to acknowledge that they are biased, but the analysis was done by the Birmingham University statisticians, and if you think that anyone can influence independent statisticians to produce a result that's not true, then you are seriously mistaken. But if you do believe that is possible, then you have got to at least partially discount these results on the grounds that Ron and Tracy and myself are biased in favour of hip resurfacing. The second piece of evidence I want to show you comes from Oxford, and Oxford certainly cannot be judged to be a group of folks who would wish to promote unnecessarily hip resurfacing above conventional total hip replacement. They obtained data from hospital episode statistics and the Office of National Statistics directly. So they did not go through the National Joint Register. The Oxford group managed to obtain the data directly from the English HES and the ONS. Interestingly, they were able to get data on death following cemented total hip replacements, uncemented total hip replacement, and hip resurfacing from 1999. So that's 13-year follow-up. So that's the best information that is available to this date. And of course, 1999 predates the setting up of the England and Wales National Joint Register. They had an amazing array of confounding variables to adjust for. They used only osteoarthritis patients. They were able to adjust for age, gender, Carlston Comorbidity Index with 22 different factors of general health, rurality, so this is to do with postcode lottery, just in case living in one area of the country gives you a higher death rate than by living in another. And they were able to adjust for social deprivation by this index of multiple deprivation. So there's a number of cemented, uncemented total hips and hip resurfacings that they had the information for. Here's what they showed. Compared to cemented total hip replacement, there was a survival advantage with uncemented total hips. So the hazard ratio, as you can see, 0.86. But there was an even more impressive advantage from a death viewpoint with hip resurfacing and a hazard ratio of 0.52. And the conclusion of this work from Oxford, which has at this stage been presented but not yet published, is this. Patients receiving hip resurfacing have reduced long-term mortality compared to patients receiving other types of hip replacement. Interestingly, the two series are saying the same thing. The highest death rate is with cemented total hip replacement, followed by uncemented total hip replacement, with the lowest death rate in hip resurfacing. Why should there be a lower death rate with hip resurfacing compared to, in particular, cemented total hips? A cemented total hip replacement generates, at the time of surgery, a very high pressure in the femur, 1400 millimeters of mercury, which is 28 pounds per square inch, which is car tire pressure. And just to see what would happen, I have attached a car tire to a human cadaveric femur. And when you switch on the pressure, then the fat and marrow in the femur evacuates onto the floor. Now you can see what goes on in total hips and resurfacings, and we have, by using a transesophageal echo probe. On the left is pre-op before a cemented total hip, and on the right is immediately after reduction, having carried out a cemented total hip replacement. And the right atrium and right ventricle are full of fat and marrow. Interestingly, the left atrium and the left ventricle are clear, and so this fat and marrow has been filtered in the lungs, stuck in the pulmonary vasculature, and doesn't get into the systemic circulation in this particular case. It is horrifying, having looked at a lot of these transesophageal echoes at cemented total hip replacement, that the embolization of fat and marrow can continue for as long as 20 minutes. Now with the BHR, we've also done transesophageal echo, and there is usually no embolization at all, but occasionally there are a couple of transient flecks of embolization, and that's it. So there's a massive difference in the amount of embolization following these two different procedures. But as we all know, the vast majority of people having had a total hip replacement wake up perfectly okay, and so there does not appear to be any obvious clinical disadvantage of having this fat embolization. The question is, could there be a long-term clinical disadvantage of having your lungs full of fat and marrow? A known cause of death following thrombotic pulmonary embolization is long-term right-sided pulmonary hypertension and right-sided heart failure. From a literature review, I cannot see anything in the literature relating to long-term pulmonary hypertension and right-sided heart failure following fat and marrow pulmonary embolization, but this for sure needs to be looked at. Now, whether this is a cause of long-term increased death following cemented total hips, I simply don't know. The other possibility is cerebral embolization, and this has been looked at in an excellent but small study from London, and they looked by transcranial Doppler at cerebral embolization. And with the Birmingham hip resurfacing, there was no intraoperative cerebral embolization, but with total hip replacement, there was 41% intraoperative cerebral embolization. Now, they did brain function tests after all these procedures, and there was no apparent reduction in brain function. Now, a lot of the vessels in the brain are end arteries, and whether there's a long-term consequence of cerebral embolization, I don't know. The next possibility is totally bizarre, and this is, could there be a cancer difference? And this information was published in the British Medical Journal, as you can see, and it looks at cancer rates in patients with metal-on-metal bearings and patients with other bearing total hip replacements. It was a very good study, controlled for age and sex of the patients, and they had 3 measures of general health that they were able to adjust for: ASA grade, ICD-10 diagnostic codes, and the previous 5 years hospital admissions. So a serious amount of information to adjust for. And they looked at any cancer and a number of individual cancers. And here's the conclusion. Furthermore, our models indicate that patients undergoing resurfacing procedures were less likely than those with alternative bearings to get a diagnosis of prostate cancer, hematological cancers, or any cancers, and had a lower risk of death. So even the England and Wales National Joint Register, who are as hostile to hip resurfacing as any group in the world, point out that there's a lower cancer incidence in hip resurfacing and a lower risk of death in hip resurfacing. And here's the cancer incidence at 5 years in men and in women. And you can see that in the non-metal-on-metal total hip replacements, there's a significantly higher cancer incidence compared to the 5-year cancer incidence in metal-on-metal resurfacing in both men and women. Now, this is totally bizarre. There's been all the chat about metal ions possibly giving you an increased cancer risk. When it's been looked at in huge detail, it turns out that the non-metal-on-metal total hip replacements have a higher cancer incidence than metal-on-metal resurfacing. This is completely different to what has happened in the past. Vesuri from Finland has been tireless in following up patients in Finland with different types of hip arthroplasty. And he has looked at a metal-on-metal population and a metal-on-polyethylene population. And in the first 20 years, there was a lower, but not significantly lower, incidence of cancer death in the metal-on-polyethylene prosthesis compared to the metal-on-metal prosthesis. And this gave rise to the initial concern that maybe in the longer term, patients with metal-on-metal hips would end up with a higher cancer rate and higher cancer deaths than metal and polyethylene implants. Turns out that in the post-20-year period, the cancer deaths are the same in both metal-on-metal prostheses and metal-on-polyethylene prostheses. But that has changed over the 35-40 years that that work was done in. Now, the recent National Joint Register data shows that non-metal-on-metal total hips have a higher cancer incidence compared to metal-on-metal resurfacing. That is quite new and it's recent. It's changed from 35-40 years ago. Here's the range of implants that we're talking about that are done throughout the country. Metal on polyethylene, ceramic on ceramic, dual mobility with a polyethylene sandwich, and metal-on-metal resurfacing. And the group with the higher cancer incidence is the non-metal-on-metal group. Now, why? Why should there be a higher cancer incidence in that first group with failure due to head neck corrosion and pseudotumor formation? Well, there's been corrosion at touching metallic parts for a long time. So it's unlikely that head neck corrosion is responsible for a higher cancer incidence. The third one of fractured bits of polyethylene, that's been going on for a long time, and it's unlikely that fracturing off of the periphery of that dual mobility insert could cause cancer. The one that concerns me is the second one of delta ceramic on delta ceramic. And this implant is relatively new and has been introduced over the last 8 to 9 years. So why do we get high metal ions, high wear, and soft tissue reactions after some resurfacing procedures? And why was the ASR so much worse than the BHR? Well, there's why you get high ions and a metal reaction in these metal and metal joints. This is a BHR that has been inserted with a high inclination angle, and you can see that the wear on the edge of this implant has gone right into the wormhole. These wormholes are in the edge of the cup to hold the introducer cables, and on the bottom photograph that's what it should look like. So there's serious amount of wear with this high inclination angle implant. Usually the wear is not so dramatic as that, and you have to use one of a few different methods. This is Redlux, which has confirmed edge wear of that cup. So why do we get edge wear on a resurfacing cup? First reason is malposition of the cup, particularly the acetabular component, and that is the surgeon's fault. Second is the use of a poor design such as the ASR, and in truth that is the surgeon's fault as well, because he has chosen to use that implant. And the third is weird patient anatomy with a femoral neck pointing in a bizarre direction, particularly prevalent in dysplasia in women. And to not get that right, or to choose to carry out a hip resurfacing in a woman with dysplasia, that's the surgeon's call as well. So when we look at a slice through a BHR cup and a slice through an ASR cup, the obvious difference is that the ASR has a big groove around the inside edge, and that groove is to attach an introducer. But it has the effect of reducing the articular surface angle, and you can see the BHR 159.4 and this small component, and the ASR of the same size 12 degrees less. 12 degrees less articular sector angle means that you only need a mild bit of acetabular component malposition and you get edge wear. And edge wear was a very potent failure mechanism of the ASR resurfacing device. Where were you when the ASR disaster was being created? Well, I was shouting warning from the rooftops. I gave a talk in Helsinki in 2005 and went on to speak at all major conferences around the world, highlighting my concerns about the ASR design. This has been on my website, and the address is outlined for you since 2005, and I didn't find many supporters. In fact, I was, in most cases, a lone voice warning this thing will fail. And all I did was incur the wrath of Dupuy Johnson & Johnson. I really wish that Dupuy J&J had listened to me and changed the design of the implant, both for their sake and for a lot of patients who have been damaged by this device. So we get two groups of people. Here's one who's screaming, "Oh hell, the bridge has fallen down." Now this is stating the blindingly obvious, and this type of person is a total nuisance and an attention seeker. We're not interested in screaming when something has failed. The useful type of person is one who analyzes it carefully and says this bridge is unsafe, we must stop the traffic and repair the bridge. There seem to be very, very few people standing up warning about the ASR at a design and early stage. Plenty who cry and shout about it when the whole thing has failed. Wouldn't a ceramic bearing be much better, you ask? Well, you might think so. I've carried out 5 ceramic resurfacings in patients who, like this one on the right, have hypersensitivity to nickel. Now, cobalt chrome has nickel contamination within the cobalt chrome, and metal on metal is not good for patients with sensitivity to nickel. And I've done here a ceramic resurfacing, and everything was great to start with, but by 2 years, unfortunately, it has failed. You can see the outline of the fractured and dislocated ceramic liner, which has displaced down to the medial neck position. So I thought it would be a good idea in this patient who had an unknown metal hypersensitivity to avoid production of any metal debris. How wrong I was. Here is the revision operation, and you can see I'm drawing off black fluid from the joint, jet black fluid. And there we are, cutting through the external rotators and the posterior capsule, loads of metal debris. And there's bits of broken ceramic, and there's the ceramic liner, and you can see that all around the rim of that thin liner it's been fractured and then dislocated. More bits of broken ceramic. There we are, dislocating the joint, and the ceramic coated head has worn through to the underlying metal. We've seen in the other patients some without wear through of the metal head and just fracture and dislocation of the ceramic liner. So I put in 5, and all 5 have failed at between 2 and 3 years. Now, this was not the best ceramic ever, but Delta ceramic is a much better ceramic from a structural viewpoint. Here, metal oxides have been added to the ceramic, and the fracture rates and explosion rates of ceramic have drastically been reduced, although not totally eliminated. However, they can squeak, particularly when there's a large-headed diameter delta, like the delta motion. And this is a publication in the Bone and Joint Journal from Melbourne, Australia. And there were 143 silent hips having had a delta motion device. That means there were 31% of the group making a noise, 11% with noises other than squeaking, 8% with unreproducible squeaking, and 13% with reproducible squeaking. That's a lot of noise, and noise in a ceramic is almost certainly an indication that the fluid lubrication layer has disappeared and you're getting direct ceramic contact. Now, there's the subtend angles in a range of different resurfacing devices with a 50mm head. They're all 160 something degrees. And by way of stark contrast, the ASR at a 50 head size has a subtend angle on the acetabular articular surface of 148 degrees, and we know that the ASR failed by edge loading and edge wear. There were a number of other failure mechanisms, but that is number one culprit. From the drawings of the Ceramtech liner, there's a spherical portion on the articular surface, which then turns into a conic section, which then turns into an edge radius. And from the drawings, you would anticipate that the subtend angle of this Ceramtech liner is 158 degrees, but actually it's not. There's a roundness tracing, and the green line shows the edge and the acetabular articular surface and the edge again, and it's well short of the 180 degree mark, which is the straight vertical black line. When you do redlux on this, what you find is that the spherical section and the conic section are blended together, and the true subtend angle is actually 149 degrees. So not 158, 149. So the ASR was 148, this delta motion is 149. The ASR fails by edge wear. The delta motion is giving 31% of people making a noise. Almost certainly that noise is due to age loading of this delta-delta joint. Does that augur well for the future? Not proven yet, but probably not. The slightly better news is with lower head sizes, 36 and 32, the subtend angle of the acetabular liner is greater. It's not 180 like a polyethylene liner, but better than the large-headed Delta Motion at 149. Now, Delta is pink because it has chromium in it, and the metals that are advertised to be added to this ceramic are strontium oxide and chromium oxide. And the literature says Biolox ceramics do not release metal ions. Here's the metal ions that the delta-delta articulation generates. This is a 10-day delta-delta pin-on-disc study, and this was done for me by the laboratory at Smith & Nephew, Memphis. And the blue is the metal ion concentration in the pre-test serum, and the red is the metal ion concentration in the serum after 10 days of running the pin and disc test. And you can see there that chromium goes up 100 times and strontium goes up about 10 times, and a few other metals go up as well. So delta-delta doesn't produce metal ions? I don't think so, not on the basis of that pin on disc test. Here's a clinical study that we did with, it's a small cross-sectional study with 20 control patients, pre-operative patients with no metal in them, and 14 delta-delta total hips, all above 1 year, who were all functioning perfectly. And we measured their blood strontium and chromium concentrations. And even in this small cross-sectional study, there is a significant increase of both chromium and strontium in the delta-delta patients. Interestingly, these are strontium and chromium levels in the blood in 2 patients who had dislocating delta-delta total hips. And the top right X I want you to look at, because that's the chromium level in one of those dislocating patients, and it's 1.2 micrograms per liter, or parts per billion. Now that is the level of chromium in the blood that you would expect from a well-functioning metal-on-metal joint. But here we've got it from a delta-delta ceramic joint. And that is quite extraordinary, because the chromium concentration in a cobalt chrome metal-on-metal joint is about 30%, but the chromium content in delta ceramic is around 0.11%. So there's about 300 times less chromium in a delta-delta joint than there is in a metal-metal joint. But still, we have seen an equivalent blood chromium level. How come? The ceramic chemists tell me that this is all to do with bioavailability. We know for certain that the chromium in a metal-metal joint is chromium 0, and we know for certain, because it has been measured, that the chromium in the debris from a metal-metal joint is chromium 3. Both of these chromiums are harmless. Now, I'm told by those who should know that the chromium in delta is definitely not chromium 0, and the ceramic chemists have no idea what the chromium from a delta-delta articulation is in the debris. And the concern, of course, is, with this unknown, could it possibly be chromium 6? Here are some chromium 3 and chromium 6 compounds. Chromium is also possible as 4 and 5, but this is rare. Chromium 3 doesn't enter cells. Chromium 6 tricks the body into thinking it's a phosphate or a sulfate and can enter cells. And chromium 6 is a known carcinogen. Now, this is some proof that chromium 3 doesn't enter cells. This is a group of people with metal-metal hips, and their whole blood chromium has been broken down into less than 1 microgram per mil, 1 to 2, 2 to 3, and 3 to 4. And on concurrent specimens, my lab folks have measured the red cell chromium, the erythrocyte chromium, and the plasma chromium. And you can see that as the plasma chromium increases, there is no increase in the red cell chromium. So that is just evidence that the chromium generated from metal-metal joints is indeed chromium-3, and it does not enter the red cells. When you look at cobalt, however, the right opposite is the case. And again, we've got the same groups. And as the plasma cobalt level goes up, the red cell cobalt also increases. So cobalt enters cells, chromium-3 does not, chromium-6 does, like cobalt, enter cells. So isn't there another bearing couple that doesn't produce metal ions and might be relatively resistant to edge loading? Probably is the answer. Here's a group that I am tortured by: women with hypersensitivity to cheap metals, and when you do lymphocyte transformation tests on them, they're allergic to nickel. So I want a non-metal metal solution for these patients. Polyethylene has been tried in the past, in the 1970s and 1980s, but this was conventional polyethylene, and with both a ceramic on polyethylene and a metal on polyethylene articulation, we had high failure rates, with 50% failure rate at 6 years in both these types of joint. But I stress, this is conventional polyethylene, and it does very badly with large head size. Here's some simulator science that shows that clearly. The lowest wear is with a 22 millimeter head, followed by the pink, which is a 28 millimeter head, and the blue, which is a 32 millimeter head, and the yellow, which is a 46 millimeter head. The bigger the head size against conventional polyethylene, the bigger the wear volume of polyethylene. And so osteolysis and other wear debris associated problems were greater with a bigger head size. When the same simulator studies are done on highly cross-linked polyethylene, there is no wear difference in the range of 22 to 46 millimeter heads. So if we would today want to design a hip resurfacing with polyethylene in it, for sure, because of the inevitable use of a large head size, we would want to use highly cross-linked polyethylene. The first problem, however, is size limitation. So when I use a 36 head with a 52 millimeter OD cup, then the best I can get is a 16 millimeter outer diameter to inner diameter articulation. And that just reflects the fact that you need a finite thickness for the metal shell, and you need a finite thickness for the polyethylene. Now, for comparison, the Birmingham hip resurfacing has a 6 millimeter outer diameter to inner diameter difference. And this is because you can put a 3 millimeter thick cup in metal in and be clinically very successful. Try doing that with a shell and a polyethylene liner, and you've got a problem. So that's what you'd end up with if you tried that. You would have a 1 millimeter thick shell and a 2 millimeter thick polyethylene. And that's not enough. You can help matters a little bit by displacing the inner center outwards and downwards. And that will increase the thickness of polyethylene in the superior wear zone area. But of course, it reduces down to 0 the polyethylene in the inferior aspect of the cup. Now, there are many cup designs from the past with an inferior cutout, and if you do an inferior cutout on this design, then you can get a reasonable thickness of polyethylene all around with a good thickness of polyethylene in the wear zone. The next problem you have is that cross-linking and remelting to get rid of free radicals seriously degrades the mechanical properties of polyethylene. And you can see with 100 kilogray radiation, cross-linking and remelting, there is a 50% reduction in fatigue crack propagation resistance in cross-linked polyethylene compared to conventional polyethylene that has been used for many years. Of course, the advantage of the cross-linked polyethylene is that we have much better wear resistance. The advantage of the conventional is we have far better mechanical properties. The mechanical properties of cross-linked polyethylene have been seen, and there have been a few publications where we have a thin cross-linked polyethylene liner and a vertically inclined cup, and there's been fracture of the superior edge of the cup. What I've been working with polymer chemists on over the past 3+ years is getting a hybrid polyethylene where you can see the darker zone is the cross-linked area and the whiter periphery is conventional polyethylene that has been molded to the cross-linked polyethylene to give good mechanical properties on the edge. So I think we can get the best of both worlds here. We can get the wear resistance from cross-linked polyethylene, but avoid the hazard of weaker cross-linked polyethylene around the edge of the cup. Now you might think, molding cross-linked polyethylene and conventional polyethylene to each other might be a weakness at the transition zone. And you can see on the right the transvanillin index showing that on the right side there's highly cross-linked poly, and on the left side there is non-cross-linked poly. That has been formed into a standard elongation to failure test, ISO 527, and when you stretch these things to failure, usually the failure mechanism is fracture across the middle of the cross-link zone. Never fractures in the conventional poly, of course. So now we have Birmingham hip resurfacing and polymix, both with 6 mm outer diameter, inner diameter difference, and we are about to start the clinical trials on polymix. So in summary, the evidence shows that BHR works well in men and women with osteoarthritis. I have shown you, of course, that women do not do as well as men, and in particular, women with dysplasia have worse outcomes. Resurfacings have a better functional outcome compared to total hip replacement. Metal-on-metal resurfacings have a lower risk of cancer compared to non-metal-on-metal total hip replacements. And BHR has a lower death rate compared to total hip replacement patients. I've shown you my concerns about delta-delta ceramic. There's a published 31% incidence of squeaking of these articulations. Certainly delta-delta is in the group of implants on the National Joint Register with an increased risk of cancer, although I must stress that the higher cancer rate has not been attributed specifically to the delta-delta joint. I've shown you chromium release, and there's a worry about what sort of chromium that is. Could it be chromium 6? Because that is certainly not harmless. A lot of work needs to be done on this. With polyethylene, the preferable polyethylene now is cross-linked polyethylene, which has much lower wear than conventional, but is best used in thick layers. There is a small incidence of rim fracture with a thin poly cup and a highly inclined implant. And there's some concerns about oxidation. Some studies have shown a 20% oxidation rate at 2+ years on retrieval studies. What we're interested in at the moment, particularly for patients with known metal hypersensitivity, is a hybrid component called polymix, where the articular zone is cross-linked polyethylene and the periphery of the cup is the stronger conventional polyethylene. And time will tell if that turns out to be a preferable implant. I thank you for your attention.